put up some slides for just to chat about transplantation. So I would prefer that I'm interrupted, so stop me, ask questions if I'm not clear about things. So we're about 50 years now after the first transplant. So the transplantation started off in two centres, one in Pittsburgh in the States, and the other in Cambridge back in the 1960s. And really for a long time it was an experimental therapy, so patients did really poorly. There was not very effective immunosuppressive drugs, and it really wasn't until the 1980s that it was an accepted medical therapy. In Australia, the first transplant unit was set up in Sydney in the mid-80s, and a few years later there was centres set up at the other capital cities around Australia, and there's now a transplant centre essentially for every state with the exception of Tasmania. There's a quiz for you. Who remembers what those slides, anyone know what those slides are from? Anybody? Yeah, so the first one's obviously Sydney Harbour, and the second one is the Queen opening of Parliament House, and this is in 1988. And that was the year that the transplant program started in Victoria. So it was a long time ago. Interest rates were standards. And the Austin in Melbourne performed its first ever transplantation in mid-1988. The fellow was by then, maybe you'd call him middle-aged these days, but then he was considered an elderly fellow. And he had his liver disease wasn't diagnosed, but this is because it was the mid-1980s, and he actually had hepatitis C, and the tests available for hepatitis C weren't developed until the late 1980s. And he was dying from liver failure, and in that first year, back in 1988, there was just 8 patients that were assessed and listed for transplantation. And this is a slide of the medical staff and patient from the first transplant. And I want someone to tell me who the patient is.
Sweater.
Adam?
The guy wearing a sweater. He had a happy face.
Well done. So I'm really disappointed actually, because I usually like it when people pick the wrong person. And I'll just go through them all. So the fellow on the far right is the guy called Larry McNichol, and he was the transplant anaesthetist, and he was there from the 80s and retired just a couple of years ago. To his left is the professor of cardiac surgery. And in the early days of transplantation, heart surgeons did some of the blood vessel joint, so he was there to do that. Anyone know who that funny looking fellow in the middle is?
Very familiar. I can't remember his name.
He was the health minister at the time. His name's David White. And Bob Jones is the surgeon standing up at the back. He was the surgeon who helped set up the program in the 80s, still working there. The patient's in front, Emil. And to the left is a guy called Ken Hardy, who was the surgeon at the Austin Hospital who actually developed and set up the program. And Emil obviously got through his transplant operation and survived for 20 years and eventually died from cardiovascular disease. And early on, transplantation in Victoria was a sort of very niche program. In yellow were the patients transplanted per year, so for maybe 6 years after the program was set up, we were doing just 10 or 20 transplants per year. And in the red bars are the people who were put on the list per year. They were roughly in the early days of transplantation. But for a long time it was not accepted by many people as a acceptable medical therapy. And even in the 80s there was a lot of gastroenterologists in Victoria who would not refer patients for transplantation because they felt it was not an appropriate therapy. It was felt to be an experimental therapy. It was a tiny program, only very small numbers of, in some ways by today's standards, very well patients were listed for transplantation. Only very good quality donor organs were utilised, and people did generally very well. This is, for anyone who reads, that lady on the right there is a lady called Inga Clendenin, and she was also one of the early people transplanted through the program in Melbourne. Ninga had an immunological liver condition. Again, she was transplanted in her 60s and died just a few years ago in her late 80s, 25 years after transplantation. And she is an academic historian, and that book there is called Tiger's Eye. It's a fantastic autobiography of her life, and she spends a lot of time talking about the psychology and mechanics of the transplant that she went through when she was in her 50s or 60s. So the reason people get transplanted is pretty easy. It's because they're going to die from their liver condition. So that's really it. When your physician is looking after, when gastroenterologists is looking after people with liver disease, if they feel they have their liver disease is becoming life-threatening, often there'll be a discussion about a referral for transplantation. And this, of course, contrasts with kidney transplantation, where you have kidney failure and you put on a dialysis machine which keeps you alive. There is no liver dialysis machine, so if you've got liver failure, generally the only route out of that problem is with transplantation. There's no liver dialysis machine. With respect to reasons people get transplanted, they're pretty simple. There's cirrhosis, which is end-stage scarring and damage. There's a really funny disease called acute liver failure, where you go from being perfectly healthy to dying from liver failure, often within weeks. That's an uncommon condition. And the other reason we transplant people is for liver cancer. And now that's probably a third of the people transplanted in the Western world because of cancer. And that is probably primary cancer, cancer that started in the liver that can't otherwise be cured. And that's a cirrhotic liver, that's a transplant operation. Those big sort of things, there are the retractors holding things, ribs, etc. out of the way. And it's a ugly looking organ, a cirrhotic liver. Those nodules, those sort of lumps there, are the bands of scarring that make up part of the diagnosis of cirrhosis. And this is a patient with acute liver failure, so this is a young woman who had been previously fit well, whose liver sort of melted down over a period of weeks to the point where she became unconscious and and that's a liver with acute liver failure, and it looks like a normal liver, except it's tiny. It's shrunk away until there's almost nothing left. And the other indication for liver transplantation is cancer, and that's sitting up right at the middle of the screen is the normal left part of the liver, you can see it, and the rest of it is a cancer. So that's a patient with liver cancer. And that's what a patient with liver cancer looks like. Often they're not dying from liver failure. Very often they are fit well, but have got an incurable cancer. And liver transplantation in Australia has been a fantastic success story. So it's gone from a very uncommon event to a relatively common event. And you can see there back in the 1988 we might have done 5 transplants. And last year at the Austin there was just over 100 patients transplanted. And that growth in liver transplantation, there's lots of reasons for it, but a lot of it relates to money put into transplantation by Kevin Rudd. So Kevin arranged for organ donor coordinators to be placed in every hospital in Australia, so that those, generally nurses, can approach families whose next of kin is dying and have a deeper meaning for them about donating their family members' organs for transplantation. So if someone is dying in Mildura or Maui or the Austin Hospital or Newcastle, there are donor coordinators there funded originally by Kevin Rudd, actually, which has markedly increased transplantation in Australia over the last 10 years. This is a slide of the total number of transplants performed in Australia each year. So now there's about 300 transplants performed. And most Sydney, like Melbourne, would perform about 100 transplants a year, and most of the other centres are actually very small. So Perth and Adelaide might perform 10 or 20, and Brisbane maybe 30 or 40. There's no centre in Tasmania. And this is a slide of indications for transplantation in adults. And you can see there the PSC wedge is the red wedge. So about 10% of transplants performed in Australia are for PSC. And there's a big risk, a big mix of everything else. This looks at data over 30 years in Australia. You can see there the pale blue says NAL, that is cancer. And that, over the last 30 years it's been 10%, but currently it's probably 30% of transplants performed in Australia. So this is sort of the mechanics of transplantation in Victoria. So there are 80 to 100 transplants performed each year, and maybe 10 or 20% of those are for children and the rest are for adults. The average weight is about 10 months. The mean age is in the 50s, so the average patient probably is someone who's in their 50s. But there's this big spread of age, as you can imagine, from neonates to people who are in some stage in their early 70s. So there's no upper age limit that would preclude people from transplantation. And this is survival, so this is how well people do, and this is, as you can see, the Victorian data for the last 10 years. And I look at this data and think that transplantation is amazingly successful, and that that's days on the bottom axis there, so 2,500 days, I guess, is about 8 years. And about 90% of patients are alive 8 years after their transplantation. There's a fall off in the first year after transplantation because of complications from the operation, things going wrong. But after that, generally people live generally people would be expected to survive 4 decades, remembering that a 55-year-old who lives for 20 or 30 years after their transplantation is going to most often die from the things that normal 70 or 80-year-olds die from. The graph, that is everybody, and the graph for children is amazingly good. Essentially, there's a risk, obviously, with transplantation early after the operation, but after that, they do incredibly well for decades and decades and decades. You've probably been through all of this with previous speakers, but liver disease progresses slowly along a reasonably predictable course. And so there's a healthy liver on the left, and inflamed liver, and that can be inflamed from PSC, alcohol, being overweight, all sorts of things. And we end up with a scarred, damaged liver, and sometime after that you can end up with either liver failure or liver cancer. And this is what people look like with, if that's what we call compensated cirrhosis, and these are people walking around who are perfectly well, who've got liver damage, because the livers are amazingly tough, and they actually cope until there's almost nothing left. So there's plenty of people out there, general population, walking around who would not know have liver disease, who've got cirrhosis. As cirrhosis and damage progresses, it can be a relatively small window between early symptoms getting quite poor and then your liver copes until it hasn't got much life left in it. And so people with healthy livers look exactly like people with cirrhotic livers most often, and people can get very sick at the end. So how do you get transplanted? What are the mechanics of it all? Well, your local doctor would realise that you are getting sick and there is little hope of improvement without transplantation, and that's his or her job. They would normally then send you off to a transplant doctor for an opinion about whether transplantation is the right thing. So you'd be sent from your specialist to a liver transplant specialist for an opinion about whether transplantation is the right thing or not. And the liver physician's job is really to make sure that transplantation is the right solution. So you need to make make sure there's no simpler way to get the liver better, and very often there is. You need to make sure the patient's well enough to be transplanted. You need to make sure they're psychologically well enough to look after themselves, take their tablets, come to clinic, etc. For the next 20 or 30 years. Keep pressing the button, my apologies. If a transplant physician feels that someone is suitable for transplantation, then they go through a formal process of test to make sure they're physically up to it, make sure their heart, lung, kidneys are fine, and a psychological evaluation to make sure they're going to be compliant with their medical care. It's only after all of this stuff is done that patients are placed on the active liver transplant waiting list. And organs, and then they're in the queue essentially, then they are waiting with 50 other people for a suitable donor. And people are ranked, so there needs to be some sort of ranking system. And the ranking is organs are allocated by blood group, which there's only 3. Size, so a really big donor liver won't fit into the person, has to fit. And then by need, so there's this MEL, which is a computer-derived number from people's blood tests that predicts how bad the liver is. And that's how people are ranked on the waiting list, so it's by their blood tests. So that removes any sort of arbitrary Part 2 allocation of organs. And as I said before, the average waiting time at the Austin Hospital is about 10 months.
Medical
So there'll be people put on the waiting list who are really sick, you might wait, they might be under the top of it, and put on the list, so they might wait a few months. And others who are put on and whose liver disease may stabilise or even improve a bit, who might wait much longer than a year.
Is there any blood group that is rare or not as conducive as other blood groups, or is it?
No, amazingly. So there's, I said 3, but there's actually a 4th, there's a really rare blood group. And the ratio between donor blood group and recipient blood group is the same, it's 1:1. So if you are blood group A, that's a third of the population, then you'll be waiting with 15 people, but a third of donors will be blood group A. So it goes, it sort of evens out. So there's no higher risk of not getting an organ or lower risk depending on blood group. And part of I had that slide earlier on which looked at really quite marked growth in numbers of transplants that's happened over the last 30 years, and part of that I said was from Kevin Rudd. There's lots of other reasons. And one is because of surgical advances, and that is the number of surgical advances that allow us to do more transplants. And one is the issue of split liver transplantation, where a donor liver can be divided in 2, and a big chunk given to an adult and a small chunk given to a baby. Living donor transplantation is where part of the liver is taken out of a healthy person and put into someone who needs a transplant. And that is done in Australia rarely for parents to children. So taking out a small amount of liver from an adult is a big operation, but not an enormous operation. So to stop kids dying on the waiting list, for example, the Austin would perform maybe just one adult to child or living-related transplantation annually, so not many. But there is generally no adult to adult transplantation in Australia. There is in some countries overseas, and that is mainly because of concern. It's a really big operation to take out a half of your liver and donate it on to somebody else. So the primary reason that living-related transplantation in adults is not done in Australia is because of surgical concern regarding risk to the donor. Things will go wrong in the donor. And not all, but almost all people put on the transplant waiting list in Australia because of growth in organ donation will get transplanted. So there's not that much gap between organ availability that it would need really to push that risk onto well patients. Does that make sense? I'm going to stop there. Any questions, anybody?